Question 1. Topic: Interventional radiology. Vascular interventions. 58-year-old male with history of peripheral arterial disease presents with claudication in his right leg. Angiography reveals 70% stenosis of the superficial femoral artery. The interventional radiologist is considering treatment options, including angioplasty with or without stenting. Which of the following factors would most strongly indicate the need for primary stenting rather than angioplasty alone? A. Short segment stenosis 5 centimeters. B. Lesion located in the common femoral artery. C. Evidence of significant elastic recoil post-angioplasty. D. Single vessel disease with good collateral flow. Answer C. Evidence of significant elastic recoil post-angioplasty. Explanation: elastic recoil post-angioplasty occurs when the vessel fails to maintain luminal patency due to the elasticity of the arterial wall, necessitating stent placement to prevent restenosis. Short segment stenosis 5 centimeters, option A, is typically well managed with angioplasty alone without stenting unless there is a high risk of recoil. Common femoral artery lesions, B, are often treated with endarterectomy rather than stenting due to high mechanical stress and risk of restenosis. Single vessel disease with good collateral flow, option D, might allow for conservative management or angioplasty without stenting, especially in non-critical ischemia cases. Question 2, scenario-based. Topic: radiation safety and protection. Principles of radiation safety. Dr. Patel, radiologist, is performing fluoroscopically guided percutaneous nephrostomy on 75-year-old female with obstructive uropathy due to large pelvic mass. The procedure is expected to last around 30 minutes. Midway through, Dr. Patel notices that the fluoroscopy timer has exceeded 15 minutes of beam-on time. Patient has had multiple prior CT scans for cancer follow-up. What steps should Dr. Patel take to minimize radiation exposure while ensuring procedural success? A. Increase the frame rate of fluoroscopy to obtain clearer images. B. Switch to continuous fluoroscopy for better real-time visualization. C. Reduce pulse rate, use last image hold, and increase collimation. D. Position the patient farther from the X-ray source to reduce dose. Answer C. Reduce pulse rate, use last image hold, and increase collimation. Explanation: reducing the pulse rate lowers radiation exposure while still allowing sufficient image quality for guidance. Using last image hold ensures the radiologist refers to the last acquired image rather than using additional fluoroscopy. Increasing collimation minimizes the irradiated field, significantly reducing unnecessary exposure. Increasing the frame rate actually increases radiation dose. Switching to continuous fluoroscopy, option B, results in significantly higher radiation exposure compared to pulse fluoroscopy. Patient positioning, option D, is important but must be balanced against procedural access. Moving the patient too far from the X-ray source may degrade image quality, requiring higher radiation doses for compensation. Relevant guidelines. The International Commission Radiological Protection (ICOP) recommends using the ALARA principle as low as reasonably achievable for radiation exposure. The RANSCA Radiation Safety Guidelines emphasize using pulse fluoroscopy, collimation, and last image hold to reduce patient dose. Question 3, topic: clinical radiology and image interpretation. Emergency radiology. 43-year-old woman presents to the emergency department with sudden onset left-sided weakness and slurred speech. Non-contrast CT brain is performed and shows an area of hypodensity in the right middle cerebral artery, Mackay territory with loss of gray-white differentiation. There is no evidence of hemorrhage. What is the next best step? Management. A. Administer intravenous thrombolysis with autoplays if within the therapeutic window. B. Proceed immediately with mechanical thrombectomy regardless of symptom duration. C. Perform CT angiogram and perfusion imaging to assess for salvageable brain tissue. D. Monitor closely and repeat imaging in 24 hours to assess progression. Answer C. Perform angiogram and perfusion imaging to assess for salvageable brain tissue. Explanation: CT angiography (ETA) and CT perfusion (CTP) help determine the presence of a large vessel occlusion (LVO) and the extent of salvageable brain tissue. Ischemic penumbra versus infarcted core. Thrombolysis with autoplays (TPA) option A is appropriate if within 4.5 hours of symptom onset. Imaging assessment is still required before administration. Mechanical thrombectomy, option B, is highly effective for LVO but should be performed only if imaging confirms an occlusion and there is salvageable tissue. Delaying treatment for 24 hours, option D, is inappropriate, as early intervention significantly improves outcomes in acute ischemic stroke. Relevant guidelines. The Australian Stroke Foundation guidelines recommend CT angiography and perfusion imaging to guide decision-making for both thrombolysis and thrombectomy. The Extend and Dawn trials demonstrated that advanced imaging helps select patients for late-window thrombectomy up to 24 hours in select cases. Question 4. Physics and Imaging Technology. CT artifacts. A 55-year-old male with a history of lung cancer undergoes a contrast-enhanced CT scan to evaluate potential metastases. Upon reviewing the images, you notice streak artifacts in the posterior fossa region of the brain, significantly degrading the image quality. The scanner used was a high-energy multi-detector CT scanner, a DT. Which of the following is the likely cause of these artifacts, and what is the most appropriate technique to mitigate them? A. Motion artifact. Instruct the patient to remain still during scanning. B. Beam hardening artifact. Use dual entity CT or iterative reconstruction. C. Aliasing artifact. Increase the sampling rate and detector resolution. D. Partial volume effect. Reduce slice thickness and use thin section imaging. Answer B. Beam hardening artifact. Use dual entity CT or iterative reconstruction. Explanation. Beam hardening occurs when low-energy X-rays are preferentially absorbed, leaving behind a beam composed of higher energy photons. This leads to streak artifacts, especially in high-density areas such as the posterior fossa or near metallic implants. Y is incorrect. Motion artifacts appear as ghosting or blurring due to patient movement. More common in thoracic or abdominal scans, not the brain's posterior fossa. YC is incorrect. Aliasing artifacts occur due to undersampling, leading to wavy patterns or wire effects. This is problem with low detector resolution, not beam hardening. YD is incorrect. Partial volume effects occur when multiple tissue types are included in single voxel blurring structures rather than causing streak artifacts. Solution. Using dual CT iterative reconstruction or applying beam hardening correction algorithms can help mitigate this artifact and improve image quality. Question 5. Interventional radiology. Oncologic ablation. A 62-year-old woman with hepatocellular carcinoma HCC is being evaluated for tumor ablation therapy. The patient has a single 3.5 centimeters lesion in segment Roman of the liver without vascular invasion or extrahepatic spread. Which of the following ablative techniques is most appropriate in this case? A. Radiofrequency ablation, RFA. B. Microwave ablation, MOAB. Transarterial chemoembolization, TACE. D. Cryoablation. Answer B. Microwave ablation, MOA. Explanation. Microwave ablation MIA are generally preferred for tumors larger than 3 centimeters because it produces a larger ablation zone, is less affected by tissue impedance, and has shorter procedural times. Y is incorrect. Radiofrequency ablation RFA is effective for tumors 3 centimeters. Question 6. Clinical radiology. Emergency imaging in trauma. A 34-year-old male presents to the emergency department after a high-speed motor vehicle collision. He is unconscious, has a Glasgow Coma Scale (GCS) score of 7, and is suspected of having a severe traumatic brain injury (TBI). A non-contrast CT brain is performed, revealing a biconvex hyperdense collection in the right temporoparietal region. The midline shift and uncal herniation signs. Which of the following is the most likely diagnosis and what is the appropriate next step? A. Epidural hematoma at immediate neurosurgical evacuation. B. Subdural hemome at a conservative management with follow-up imaging. C. Diffuse axonal injury arrive brain for further assessment. D. Cerebral contusion monitor in the ICU with supportive care. Answer A. Epidural hematoma at immediate neurosurgical evacuation. Explanation. A biconvex hyperdense collection on CT strongly suggests an epidural hematoma, often due to middle meningeal artery rupture following temporal bone fractures. This condition can rapidly progress to brain herniation. YB is incorrect. Subdural hematomas (SDH) appear as crescent-shaped collections and often result from bridging vein seen in elderly or anticoagulated patients. YC is incorrect. Diffuse axonal injury (DI) is characterized by petechial hemorrhages in the corpus callosum and brainstem and is best diagnosed using MRI, not ET. YD is incorrect. Cerebral contusions are typically patchy hemorrhagic lesions at the gray-white matter junction, requiring IQ monitoring, but not urgent surgery. Management. ED requires urgent craniotomy. Hematoma evacuation to prevent brainstem compression and death. Question 7. Scenario-based. Radiation safety and protection. Dr. Mitchell, a radiologist, is reviewing imaging studies when he notices that a pregnant patient in her first trimester was inadvertently exposed to fluoroscopy-guided interventional procedures. The fluoroscopic time was 10 minutes with an estimated dose of 20 mg to the fetus. The patient is distressed and wants to know if her pregnancy is at risk. What is the appropriate response by Dr. Mitchell? A. Reassure the patient that radiation doses below 50 mg pose no significant risk. B. Recommend immediate termination of pregnancy due to potential fetal malformations. C. Suggest MRI evaluation to assess radiation-induced teratogenic effects. D. Advise delaying further imaging until after delivery to avoid additional radiation exposure. Answer A. Reassure the patient that radiation doses below 50 mg pose no significant risk. Explanation. According to the International Commission on Radiological Protection (ICOP) and American College of Radiology (ACA) guidelines, fetal doses below 50 mg are not associated with teratogenic effects or increased miscarriage risk. Why B is incorrect. Termination is not justified at doses below 100 mg. Why C is incorrect. MRI cannot assess radiation damage at the cellular level. Why D is incorrect. While unnecessary radiation should be avoided, medically indicated imaging should not be postponed. Guidelines. Radiologists must follow the ALORA as low as reasonably achievable principal and pregnancy risk communication protocols to manage such incidents. Question 8. MRI physics. Diffusion-weighted imaging. Dwight, a 45-year-old male presents with sudden onset left-sided weakness and slurred speech. An urgent MRI brain with diffusion-weighted imaging. Dwight, an apparent diffusion coefficient AC mapping is performed. The Dwight sequence shows hyperintensity in the right middle cerebral artery Mackay territory, while the corresponding ACAP shows hypointensity in the same region. Which following best describes the pathophysiological process responsible for these findings? A. Cytotoxic edema due to acute ischemia. B. Vasogenic edema from blood-brain barrier breakdown. C. Restricted diffusion from hemorrhagic conversion. D. Increased diffusion due to chronic infarction. Answer A. Cytotoxic edema due to acute ischemia. Explanation. Dwight hyperintensity plus AC hypointensity indicate restricted diffusion seen in acute ischemic stroke due to cytotoxic edema from failure of the Nake-Apis pump. YB is incorrect. Vasogenic edema seen in tumors, abscesses shows high AC hyperintensity due to extracellular fluid accumulation. YC is incorrect. Hemorrhagic infarcts may have signals, but restricted diffusion is not a hallmark feature. YD is incorrect. Chronic infarcts show increased AC hyperintensity, not hypointensity due to cell membrane breakdown. Question 9. Chest radiology. Ill diagnosis: a 60-year-old male with progressive dyspnea and chronic dry cough undergoes a high-resolution EUA of the chest. The scan reveals subpleural honeycombing, reticulations, and traction bronchectoses predominantly in the lower lobes. No significant ground glass opacities or pleural effusions are noted. What is the most likely radiologic diagnosis? A. Usual interstitial pneumonia (UIP). B. Nonspecific interstitial pneumonia (NSIP). C. Hypersensitivity pneumonitis at HP. D. Sarcoidosis. Answer A. Usual interstitial pneumonia (UIP). Explanation. UIP pan-atus T are characterized by honeycombing, reticulations, and lower lobe subpleural predominance. YB is incorrect. NSIP shows ground glass opacities and fibrosis, but honeycombing is uncommon. YC is incorrect. HP shows centrilobular nodules and ground glass opacities, often upper lobe predominant. YD is incorrect. Sarcoidosis favors an upper distribution with perilymphatic nodules and mediastinal lymphadenopathy. Question 10. Interventional radiology. TIPS procedure: a 50-year-old male with cirrhosis and recurrent variceal bleeding undergoes evaluation for a transjugular intrahepatic portosystemic shunt. TIPS is hepatic venous pressure gradient. ECG is 16 m8G. Which of the following is the primary goal of a TIPS procedure? A. Reduce ECG to below 12 m8G. B. Completely normalize portal venous pressure. C. Increase hepatic arterial blood flow. D. Bypass portal hypertension without altering systemic circulation. Answer A. Reduce ECG to below 12 mAg. Explanation. The goal of TIPS is to reduce ECG 12 mAg to prevent variceal bleeding. YB is incorrect. TIPS does not normalize portal pressure, only reduces it. YC is incorrect. Hepatic arterial blood flow may decrease due to shunting. YD is incorrect. TITs can cause systemic complications such as hepatic encephalopathy. Question 11. Pediatric radiology. Neck in neonates. A preterm neonate, 28 weeks gestation, develops abdominal distension, bloody stools, and feeding intolerance. An abdominal X-ray reveals pneumatosis intestinalis was the most likely diagnosis. A. Necrotizing enterocolitis, neck. B. Meconium ileus. C. Midgut volvulus. D. Hirschsprung disease. Answer: A. Necrotizing enterocolitis, neck. Explanation: Neck is a life-threatening intestinal disease in preterm neonates with pneumatosis intestinalis intramural gas as the hallmark finding. YB is incorrect. Meconium ileus is linked to cystic fibrosis and causes microcolon on contrast enema. YC is incorrect. Midgut volvulus presents with bilious vomiting and whirlpool sign on imaging. YD is incorrect. Hirschsprung is characterized by failure to pass meconium and a transition zone on barium enema. Question 12. Neuroradiology. Spinal cord compression. A 65-year-old male with prostate cancer and worsening back pain undergoes MRI spine. The scan shows an extradural mass compressing the spinal cord with cord signal changes on tweighted images. What is the most appropriate next step? A. Urgent neurosurgical consultation and high-dose steroids. B. Radiation therapy alone. C. Chemotherapy alone. D. Conservative pain management. Answer: A. Urgent neurosurgical consultation and high-dose steroids. Explanation: Spinal cord compression from metastasis is an emergency requiring high-dose steroids, dexamethasone, and urgent decompression. YB is incorrect. Radiation is useful but not the first-line emergency treatment. YC is incorrect. Chemotherapy does not provide rapid relief of compression. YD is incorrect. Conservative management is inappropriate. Acute neurological compromise. Question 13. Breast imaging. BI-RADS classification. A 45-year-old female undergoes a screening mammogram. The report describes a spiculated, high-density mass with microcalcifications in the left breast, classified as BI-RADS 5. What is the next step in management? A. Core needle biopsy. B. Follow-up mammogram in 6 months. C. Antibiotic therapy and repeat imaging. D. Reassurance and routine follow-up. Answer: A. Core needle biopsy. Explanation: BI-RADS 5 lesions have a 95% chance of malignancy and require biopsy. YB is incorrect. A 6-month follow-up is appropriate for BI-RADS 3 lesions, probably benign. YC is incorrect. Antibiotics are not indicated for suspected malignancy. YD is incorrect. Reassurance is inappropriate for highly suspicious lesions. Question 14. Neuroradiology. Brain tumors and imaging features. A 55-year-old male presents with progressive headaches and personality changes. MRI brain shows a heterogeneous, irregularly enhancing lesion with central necrosis in the right frontal lobe, crossing the corpus callosum, butterfly appearance. There is surrounding vasogenic edema and increased cerebral blood volume, CBV. Perfusion imaging. Which of the following is most likely diagnosis? A. Glioblastoma GBM. B. Primary ENS lymphoma. C. Anaplastic astrocytoma. D. Meningioma. Answer: A. Glioblastoma GBM. Explanation: GBM, a grade Roman ostracioma, is the most common aggressive primary brain tumor in adults, often presenting with ring enhancement, necrosis, and corpus callosum involvement. YB is incorrect. Primary ENS lymphoma appears as a homogeneously enhancing lesion without necrosis. YC is incorrect. Anaplastic astrocytoma is typically non-necrotic and does not enhance as aggressively. D is incorrect. Meningiomas are extraxial, well-circumscribed, and often dural-based. Question 15. Interventional radiology. Stroke management. A 70-year-old female with atrial fibrillation presents with acute left-sided weakness. NIS score 18. CT angiography reveals an occlusion of the right middle cerebral artery MM segment. CT perfusion shows a large penumbra with a small infarct core. What is the most appropriate next step? A. Mechanical thrombectomy. Roman alter plays to PA only. C. Anticoagulation with heparin. D. Conservative management. Answer: A. Mechanical thrombectomy. Explanation: Endovascular thrombectomy is the standard of care for large vessel occlusion in stroke with a salvageable penumbra. YB is incorrect. Roman alteplase is beneficial only if within 4.5 hours, but thrombectomy is preferred for large vessel occlusions. YC is incorrect. Heparin is not recommended in acute stroke due to hemorrhagic risk. YD is incorrect. Conservative management. Inappropriate given the large salvageable brain tissue. Question 16. Chest radiology. Lung cancer staging: a 65-year-old smoker presents with cough, weight loss, and hemoptysis. CT chest shows a 3 cm right upper lobe mass with ipsilateral mediastinal lymphadenopathy and a pleural effusion. According to the TNM staging system, what is the likely clinical stage of this lung cancer? A. Tidament. A. Stagier. C. Stagier. B. Stidrome. Answer C. Stagier. Explanation: Stagier lung cancer involves mediastinal lymph node involvement in and pleural effusion. YD is incorrect. Stidromna requires distant metastases beyond the thorax. Question 17. Musculoskeletal imaging. Osteomyelitis versus Charcot joint. A 58-year-old diabetic patient with foot ulcer and swelling undergoes MRI, which shows bone marrow edema, subchondral cysts, and periarticular soft tissue swelling in the mid-hip. Tweighted images show low signal intensity in bone marrow, and post-contrast images show patchy enhancement. Which imaging feature best differentiates osteomyelitis from a Charcot joint? A. Bone marrow signal extending beyond subchondral bone. B. Joint subluxation or dislocation. C. Soft tissue swelling. D. Periosteal reaction. Answer A. Bone marrow signal extending beyond subchondral bone. Explanation: Osteomyelitis shows bone marrow edema extending beyond joint margins, while Charcot joints have subchondral preservation. YB is incorrect. Subluxation is common in Charcot arthropathy, not osteomyelitis. Question 18. Abdominal radiology. Appendicitis versus Seckel diverticulitis. A 30-year-old male presents with right lower quadrant pain, fever, and nausea. CT abdomen shows a thick-walled, fluid-filled structure with periappendical fat stranding but no intraluminal air or fecalith. What is the most likely diagnosis? A. Acute appendicitis. B. Seckel diverticulitis. C. Crohn's disease. D. Epiploic appendicitis. Answer A. Acute appendicitis. Explanation: thick-walled, fluid-filled structure plus fat stranding suggests appendicitis. YB is incorrect. Seckel diverticulitis occurs in older patients and lacks a tubular structure. Question 19. Nuclear medicine. Thyroid cancer imaging. A 45-year-old female with papillary thyroid carcinoma undergoes post-thyroidectomy radioiodine scan. The scan shows radioiodine uptake in the neck and diffuse pulmonary uptake. What does this pattern suggest? A. Pulmonary metastasis. B. Normal post-surgical uptake. C. Thyroiditis. D. Parathyroid adenoma. Answer A. Pulmonary metastasis. Explanation: diffuse pulmonary uptake in a post-thyroidectomy patient is highly suspicious for metastasis. YB is incorrect. Normal uptake is limited to the thyroid bed, not the lungs. Question 20. Interventional radiology. Uterine fibroid embolization. A 42-year-old female with heavy menstrual bleeding and anemia undergoes uterine artery embolization (UE) for fibroids. 1 week post-procedure, she develops fever, severe pelvic pain, and leukocytosis. What is the most likely complication? A. Uterine infarction and infection. B. Pulmonary embolism. C. Ovarian failure. D. Ureteral injury. Answer A. Uterine infarction and infection. Explanation: post-UE ischemic necrosis of fibroids can lead to secondary infection. Why C is incorrect. Ovarian failure is a rare but long-term effect, not acute. Question 21. Chest radiology. Pulmonary embolism imaging. A 32-year-old pregnant woman presents with acute dyspnea and pleuritic chest pain. Pulmonary angiogram (PA) shows filling defects in segmental pulmonary arteries. What is the recommended treatment? A. Low molecular weight heparin A or B. Warfarin. C. Thrombolysis. D. IVG filter. Answer A. Low molecular weight heparin A. Explanation: a first-line treatment for P in pregnancy. YB is incorrect. Warfarin is teratogenic. Question 22. MRI physics. In relaxation, the radiologist is performing brain MRI with the tweighted sequence. The patient has received gadolinium contrast and the radiologist notices enhancement of certain brain structures. Which of the following factors primarily determines T contrast in the MRI sequence? A. Proton density differences. B. Spin-spin relaxation. C. Spin lattice relaxation. D. Diffusion of water molecules. Answer C. Spin lattice relaxation to explanation. T. Contrast is determined by spin lattice relaxation, which measures how quickly protons return to equilibrium after RF pulse excitation. Y is incorrect. Proton density is more relevant in proton density weighted imaging. YB is incorrect. Relaxation spin affects weighted imaging. No. Question 23. Pediatric radiology. Necrotizing enterocholitis. A 28-week premature infant in the NICU develops abdominal distension, bloody stools, and metabolic acidosis. An abdominal X-ray reveals pneumatosis, intestinalis, and portal venous gas. What is the most likely diagnosis? Say, necrotizing enterocholitis, NEC. B. Intussusception. C. Hirschsprung disease, deep malrotation with midgut volvulus. Answer A. Necrotizing enterocholitis, NEC. Explanation. Pneumatosis, intestinalis, intramural gas, and portal venous gas are hallmark signs of NEC. YB is incorrect. Intussusception presents with a target sign on ultrasound, not pneumatosis. YC is incorrect. Hirschsprung disease presents with delayed meconium passage, not pneumatosis. Question 24. Cardiac imaging. Aortic dissection on CT angiography. A 60-year-old male with hypertension and severe chest pain radiating to the back presents to the emergency department. CT angiography shows an intimal flap separating two lumens in the ascending and descending aorta. Which classification system best describes this condition? A. DeBakey type I. B. DeBakey type Omen to Stanford type B. D. Stanford type A. Answer D. Stanford type A. Explanation. Stanford type aortic dissections involve the ascending aorta and require emergent surgical repair. Y is incorrect. DeBakey type I involves both the ascending and descending aorta, but Stanford classification is more commonly used in clinical practice. Question 25. Gastrointestinal radiology. Small bowel obstruction on seat. A 45-year-old male with a history of prior abdominal surgery presents with crampy abdominal pain, nausea, and vomiting. CT abdomen shows dilated small bowel loops, 3 cm fluid levels, and a transition point, which feature on CT suggests strangulation rather than simple obstruction. A. Closed loop configuration with mesenteric swirling. B. Single transition point without mesenteric congestion. C. Mild dilated loops without free fluid. D. Isolated colonic distension. Answer A. Closed loop configuration with mesenteric swirling. Explanation. Strangulation obstruction is characterized by closed loop obstruction, bowel wall thickening, and mesenteric congestion or swirling. YB is incorrect. A single transition point without mesenteric congestion suggests a simple obstruction, not strangulation. Question 26. Genitourinary imaging. Renal cell carcinoma and ET at MRI. A 68-year-old male undergoes an abdominal CT for hematuria, revealing a heterogeneously enhancing renal mass with areas of necrosis. Which feature is most suggestive of clear cell renal cell carcinoma REC? A. Strong enhancement on corticomedullary phase. B. Low attenuation on arterial phase. C. No enhancement after contrast. D. Uniform enhancement with no necrosis. Answer A. Strong enhancement on corticomedullary phase. Explanation. Clear cell RCC shows intense enhancement due to rich tumor vascularity, particularly in the corticomedullary phase. YB is incorrect. Low attenuation suggests a benign lesion. E. G. Cystina RE. Question 27. Interventional radiology. Complications of TIPS procedure. A 55-year-old male with cirrhosis and refractory ascites undergoes a transtubular intrahepatic portosystemic shunt TIPS. He develops worsening confusion post-procedure. What is the most likely cause of his symptoms? A. Hepatic encephalopathy. B. Portal vein thrombosis. C. Hepatic infarction. D. Biliary leak. Answer A. Hepatic encephalopathy. Explanation. TIPS shunts blood away from the liver, reducing detoxification of ammonia, leading to hepatic encephalopathy. YB is incorrect. Portal vein thrombosis presents with abdominal pain, not confusion. Question 20. Chest radiology. Pulmonary alveolar proteinoid. A 40-year-old male with progressive dyspnea and no significant smoking history undergoes to CT of the chest, which shows a crazy paving pattern, ground glass opacities with interlobular septal thickening. What is the most likely diagnosis? Say, pulmonary alveolar proteinosis, PAP. B. Interstitial pulmonary edema. C. Usual interstitial pneumonia. U. D. Pulmonary embolism. Answer A. Pulmonary alveolar proteinosis. PAP. Explanation. PAP classically presents with a crazy paving pattern due to alveolar surfactant accumulation. YB is incorrect. Pulmonary edema can also show ground glass opacities but lacks crazy paving. Question 29. Head and neck radiology. Parotid tumors on MRI. A 55-year-old male presents with a slow-growing painless parotid mass. The MRI reveals a well-circumscribed lobulated lesion with high T signal and intense post-contrast enhancement. Which of the following is the most likely diagnosis? A. Pleomorphic adenoma. B. Warthin tumor. C. Mucoepidermoid carcinoma. D. Lymphoma. Answer A. Pleomorphic adenoma. Explanation. Pleomorphic adenomas are the most common benign salivary gland tumors and appear as T hyperintense, well-defined lesions with post-contrast enhancement. YB is incorrect. Warthin tumors occur more commonly in smokers and show low T signal. Question 30. Nuclear medicine. Bone scan findings in prostate cancer. A 72-year-old male with prostate cancer and elevated PSA undergoes a bone scan revealing multiple focal areas of increased uptake in the axial skeleton. What is the most likely cause? A. Metastatic prostate cancer. B. Paget's disease. C. Osteomyelitis. D. Multiple myeloma. Answer A. Metastatic prostate cancer. Explanation. Prostate cancer commonly metastasizes to bone, showing multiple sclerotic lesions on bone scan. YD is incorrect. Multiple myeloma usually shows cold lesions due to lytic bone destruction.